So today I'm sitting with two of the prominent specialists in their fields, Dr. D.K. Pradhan, neurosurgeon, Dr. Apratim, interventional neurologist. I am myself Dr. Sujoy, emergency in charge. So we're just going to have a discussion today about stroke. I understand we're having a World Stroke Day coming on 29th, which is an important part for all of us, neurologists, people, and including emergency people. So if you don't mind, I'm just going to ask a few questions to both of you. Okay? And we'll just discuss and see and discuss about it and have a nice informal, formal conversation about it. Shall I ask Dr. Pratim? Dr. Pratim, if you don't mind me asking you, so just give me a brief description. What is stroke? Because I think a lot of people in the crowd they don't understand the term we speak with each other, stroke. So they just want maybe a simplified way of what is stroke.
So, before I start what is stroke, I must clarify one simple thing. Stroke is purely a brain disease. So, it is not related any way to heart. This is number one. Number two, it's a disease of the brain which involves the brain blood vessels. So, it's either a blockage in any of your blood vessel of the brain by which a part of your brain starts rotting, and as it doesn't get blood supply, that we call as an ischemic stroke. Another part of the stroke is when your blood vessel ruptures and you have a bleed inside the brain. That is called as a hemorrhagic stroke.
Lovely. Thank you so much. So, hemorrhagic basically means just the blood which is just breaking from the vein and causing something, you have blood filled over. Okay, Dr. Pradhan, in hemorrhagic stroke, usually, I mean, all these stroke patients, what type of symptoms, what signs will they come in with, or what problem they'll face? If you could just enlighten us.
Stroke is a very big term, okay? And what he has said, there are two types of stroke. One is the ischemic stroke, one is the hemorrhagic stroke. See, as a stroke unit, hospital should have a good team, and we are very fortunate to have everything. We have the stroke team in which we have the neurosurgeon, the neurologist, the intensivist, the emergency people, as well as the interventionist. We need a very good interventionist, who goes directly with blood vessels and treats that. So we have a good team here in AMRI, Mukundapur. So now the symptoms they present with depends on the area of the brain which is affected. Brain for us is not a single part; it's a playground for us. There are some parts of the brain which are very important for day-to-day activities, for high mental function, the cognition, the memory part, the speech part. So the symptoms will depend on where there is affection in the brain. Again, right and left again makes a big difference. The left part of the brain is more eloquent. What we see. Again, see now coming to the common presentation. See, if there is a hemorrhagic stroke, mostly due to high blood pressure or due to metabolic problem like diabetes and many other causes, that will depend on the area. Most commonly, they present with the kind of weakness on the opposite side, from the opposite side of the body where the stroke has occurred. Suppose there is a stroke on the left side of the brain, they present with weakness on the opposite side, that's on the right side, either of the upper limb or the lower limbs, or both together. They come with speech disturbances. Either they are completely not able to speak, or there's some slurring of the speech, or sometimes they cannot understand what people are saying. So these are the most common presentation with which the patient comes to us.
Right. So as you rightly said, so it's mainly weakness of any side of hand or legs, or not able to speak properly. And at times we have this balance issues also. I think in our department we also follow something called a Belfast thing. So Dr. Apratim, if you don't mind, can you enlighten us what is Belfast?
So basically, it's a mnemonic we use to simplify the identification of stroke symptoms, so that the relatives can identify the patients with stroke and bring them earliest to the stroke hospital, because as you know, time is brain. So Belfast, each letter stands for a particular symptom, and you have to add an acute onset to it. So anything which is acute onset, or when the patient relatives tell from this time onwards, the patient has B means balance, any difficulty in balance, E means eye, difficulty in vision, L means loss of consciousness, any sudden loss of consciousness, or the patient suddenly becomes unconscious. F means facial droop, so the patient has a facial deviation or one side dips down. A stands for arm, which signifies hand or lower limb weakness, and S stands for speech, which means either the speech gets slurred or the patient is unable to understand what you're speaking. And T stands for time, because as we said, all the time since the onset of the symptom, the patient's brain continuously dies permanently. And the more time you delay, the more time it will take the patient to recover, and the poorer the prognosis will be.
Right. Thank you so much. Uh, as you said, time is the most important part when you recognize the symptom and everything. For our, for our people out there in the world, sometimes they don't know exact time, because a lot of times we in emergency see patients having symptoms, 5, 6 hours, or 7 hours, and 8 hours, and then tell us, oh, it's been there since a long time. So there must be a specific time period that we're looking at where the patient should be within us in that period of time. And I think Dr. Pradhan, if you don't mind, can tell us exact what would be the time range or time period when the patient can come into as early as possible?
As soon as possible. As soon as possible. They should go to the nearest center where there is stroke facility or the neuromedicine, neuro care is there. And we say is the golden hour is within 4 hours, right?
4.5 hours.
4.5 hours. See, this ideally this should be the situation in which they are evaluated with all the modern gadgets, and we can save many patients the debility in the patient by giving some injections or doing some intervention. So the golden hour is 4.5 hours, but sooner the better. Like the patient should come immediately. Right?
I definitely agree with you. I think sooner the better is easier way to reach the public, so that, because sometimes for them the hours may mismatch and everything. So as soon as you feel some issues is going on, some balance issue, some speech issue, somewhere where your vision issues are there, please come in and get it checked. We do a lot of scans and everything for a lot of patients. We do CT scans, MRI, and everything. And then after that, when we see there is a chance of an ischemic or a hemorrhagic, I think ischemic, Dr. Apratim, if you can just guide us. We hear this term called thrombolysis. Suddenly we hear some people saying there's something called thrombolysis or thrombectomy. If you could just guide us regarding what this is all about.
As he said, there is something called as imaging also in between. So in imaging, we must say that we all will require for, after you have identified the stroke symptoms, reach the stroke hospital. The most important thing is a basic CT scan. That's the simple thing. You rule out a bleed, you are within the window period, you satisfy the criteria for these, what you call thrombolysis, which in simpler terms is nothing but a clot buster. So there is something which is blocking your blood vessel from flowing the blood in a particular area of the brain. So you give a medication or injection through your venous channel or your arterial route, and you try to lyse or break the clot, or the clotted, the tough part of the blood which is occluding your blood vessel, and you try to restore the vasculature as in the previous. So that is what in simple term is thrombolysis. So which as per guidelines is within the 4.5 hours window from onset if you give the intravenous one, and if we have access to the intraarterial, for which we require a cath lab which is same as any cardiac cath lab, and we have a time window of around 6 hours. Having said that, we have at times extended our thrombolysis window even beyond 9 hours nowadays, based on the amount of the tissue which is actually remaining in the occluded vasculature. So the more the tissue is left, so we call it a tissue window. The more the tissue that can be saved, the better chances of recovery and a better scope of opening the vessel and restoring the vasculature and improving the patient. So in these cases, we sometimes do consider some particular imaging sequences by which we come to know how much is the amount of the remnant brain tissue which can be saved, salvageable brain tissue, and then we extend the thrombolysis window at times to even 9 hours and beyond.
All right, thank you so much for that information. There are also times when we come to hemorrhagic stroke, and sometimes I have asked some patient relatives, they come and tell me, sir, somebody told me, they come from different hospitals, they told me, sir, we have to do clipping. Like clipping and why and all this. Then they say there's an SH and they require all of that. It comes in one of the stroke because sometimes the patient can present to a sudden weakness and all this stuff. And there are also scenarios where you have a huge infarct and you sometimes do some operative procedure to help those patients. If you don't mind, can you just tell me, what type of situation where you need to do operation for those patients where there's a huge infarct and you need to do something? How can we release the pressure and what we do actually for that? Just guide us, Dr. Pradhan.
See, if a patient comes and we see there is a bleed in the brain, all bleeds are not the same. The most common I mean, bleed what you see in the stroke, the common term stroke is the intraparenchymal. That is a bleed inside the matter of the brain substance. Okay. Another other bleeds will be something outside the brain, but within the covering of the brain. That's called subdural. Another bleed is extradural, which is outside the covering of the brain. And the fourth one, very important and not to miss by any of the physicians or doctors, is the subarachnoid hemorrhage. That's a bleed within. There's an arachnoid space, and a space in the brain, something called arachnoid space. In this space, there is bleed. Whenever we find this bleed, we should be very alert and immediately get an angiogram of the brain. This is one condition in which angiogram is required. Either you get a CT angiogram or a digital subtraction angiogram to look for any vascular anomalies in the brain. In a typical case of a subarachnoid hemorrhage, we on an angiogram we find aneurysm or some other vascular malformation. These are like a ticking time bomb. This has to be treated not by medication. Medicines will not work in such conditions. You have to treat either by surgery or by intervention, in the sense that if there's a aneurysm, you can treat with clipping or coiling, and by surgical, there is the clipping. See, sometimes even aneurysm can present with a large bleed inside the substance of the brain. That's why, again, you have to be very alert. All the strokes are not the same. They have to be seen by a consultant immediately. Now, regarding the surgery, I told you about the aneurysm case. This has to be treated not by medication, by some kind of intervention. Now, when it comes to a common bleed in the brain, that's called intravenous bleed, the volume matters, the site matters where it is in the brain, and what kind of pressure it's causing to the normal structures, normal remaining structures. One thing, with experience, I can tell you, blood which is inside the blood vessels are very benign, but once they come out of the blood vessels, especially in the brain, they're very toxic. They keep on seeping through the brain substance. They cause more injury to the normal brain tissue. So, if possible, if there is a large clot, and if that's threatening the life of the patient, or there is causing more damage to normal other part of the tissue, and also depending on the site, you can intervene. We can do a surgery. Surgery these days are very, very safe. We have become more minimally invasive. We have started doing more smaller surgeries with microsurgery, by endoscopic surgery, and we remove the maximum brain, the clot in the brain with a small hole also. So what will happen is this will help in the recovery of the patients and will cause less morbidity in the long term. So again, this is the discretion of all the stroke centers and the experience of the doctors in that center.
Thank you so much, Dr. Pradhan. Lovely how you said at the end, recovery. And a lot of times we have a lot of relatives coming to us when we tell them about everything, and then they say, in simple Bengali words, Amar Baba ya Ma ঠিক হয়ে যাবে তো, আবার হাঁটতে চলতে পারবে তো, movement করতে পারবে তো, কথা বলতে পারবে তো. I think in this type of scenario, I think if you could just enlighten us from each part of your specialty, the rehabilitation process. That is, I think, one of the most important part. Dr. Apratim, if you don't mind, could you just tell us how we start with the rehabilitation process?
So, very most important, I think, whatever we have discussed till now is more of acute scenario. But in ischemic stroke also, after 24 hours, all is not lost. And we have started moving from our previous belief that a neuron, once damaged, can never be recovered back. So there is a concept of neuroplasticity, which we are harping on nowadays. And hence, rehab in all the fields of neurology are growing tremendously fast. And people coming off late with a proper rehab, which is again a teamwork. It's not a single man's job. In our center, we have a series of people like involving a speech therapist, a swallow therapist, a physiotherapist, a motor rehabilitation specialist, an occupational therapist, and a psychologist attending in the rehab center for all stroke patients, be it ischemic, be it hemorrhagic. It affects all the domains of the brain, and hence each part rehab has to be looked into. One ray of hope I want to enlighten as an interventionist that you have many of us have seen chronically paralyzed patients, and I think this World Cup or the one before, the one paralyzed patient was able to kick a ball in the opening ceremony with the help of an implant in the brain with the brain computer interface. So that's the future for us. What we are going to do is the stent rod technology. We are going to just put a single channel inside your vein in the leg or the arm, we are going to place a chip inside the vein of your brain and we're going to connect it to the computer, and the patient can probably lift his limbs. So this is the future which is coming very soon. This is all the stent road, and the future of neuro rehab is a big, big hope and new challenge.
Thank you. And Dr. Pradhan, you want to add something to this? Anything extra? Or is the same way we go about for all patients in neurosurgery?
Yeah,
Or
when it comes to rehabilitation, after the acute episode of either a hemorrhagic stroke or a ischemic stroke, the rehabilitation process will remain the same. So there's no deviation from this.
lovely. So I think we all can understand and know the fact that it's all a team effort. It starts from the beginning till the end, including the rehabilitation. A lot of people have doubt regarding that. And I hope we all should know by this that if you have any of the symptoms where you have a balance issue, speech issues, or you feel there's weakness on any arms, please do come by. Get yourself checked by the neurologist, neurosurgeon to just make sure it is not a stroke, which can be very bad at the end, which can be much more worsened. It's about prevention, and it's better than cure, right? So I think that's what we had learned. So I think we can end this session on this, and I would like to thank Dr. Apratim and Dr. D.K. Pradhan to come and talk to us. I'm sorry if I bored you all. Okay, I'm sorry if anything else, but I think it was a nice informal discussion, and hopefully the people can understand a bit more and they can come to us and we can help and guide them much more.
Last note, this was like when the things have already happened. Next episode, you can enlighten the audience regarding how to prevent stroke. So this big thing.
Absolutely.
How to go back to the society and to educate them, so that maybe they don't have to come to us. Thank you.
Right. Thank you.